the impact of gender differences in athletic training and coaching. This is all part of the Leadership and Policy course, and this will be taking place with Whitney Bailey, Jeffrey Buxton, and Stephanie Stark. Hope you enjoy. Healthcare policy implementation. This is a topic discussed in all health professions in one instance or another on a regular basis. Whether you are agreeing with what is happening or if you are debating the decision made by those higher up the chain. One of the hot topics in healthcare currently is the need for the variation in the treatment of men and women. We are all aware that there are obvious differences between males and females, yet in regards to healthcare, we are all treated the same. And looking at men and women, you have obvious differences, such as appearance and build, but you also have the not so obvious differences, so the hormonal, nutritional, and metabolic that cannot be seen on the surface. The idea we are wanting to present today will be the concept of female-specific healthcare to treat the needs of the individual patient rather than everyone being treated the same. Title IX is a buzzword that everyone has heard of and employs equal opportunities for men and women in education and in athletics. It states that equal treatment be made available for both female and male student athletes in the provisions of many areas, including medical and training facilities and services, along with support services. Now I know, as healthcare professionals, that we are all treating our patients equally on the field or court, or in our athletic training facilities. However, when we are developing treatment plans for our patients, do we truly consider the differences between males and females before implementing a rehabilitation program or other treatment? Or what about the track coach that has both males and females on the team? Are they employing strategies that are the best for the athletes they are working with? The goal of this presentation will be to outline a few ramifications and policies that could be implemented in your facilities to better serve those that you are working with. According to the American Psychiatric Association, women are nearly twice as likely as men to develop depression, anxiety, and eating disorders. Furthermore, the NCAA's own data states that heart problems for women often resulting of eating disorders and suicide as the second and third leading causes of death among student athletes. There are other female-specific ramifications that can have an effect on athlete training services that we need to make sure we are keeping in mind whenever we are working with our student athletes. ACL injuries are common in adolescent girls and women, especially in those participating in sports such as soccer and basketball. These are mainly non-contact type injuries associated with jumping, cutting, and pivoting, and are probably multifactorial in nature. Factors that contribute to ACL injury include lower extremity malalignment, decreased core stability, and muscle strength imbalances, particularly between the quadriceps and hamstring muscles. Implementing specific screening protocols to truly assess hamstring to quadriceps strength would be beneficial in the prevention of ACL injuries. However, this is often rushed through or skipped due to the time needed to complete. Implementing a more thorough pre-participation examination screening for our female athletes needs to be brought to the forefront. Being able to gather a more in-depth look at the hormone levels, bone densities, mental health status, even gynecological screening may reveal deficiencies that will predispose our female athletes to injuries such as ACL tears, stress reactions, or larger issues putting our athletes at risk. It has been shown that hormonal influences play a role in injuries as seen with ACL ruptures. Female high school and collegiate athletes should be screened for components of the female athlete triad, such as eating disorder, menstrual dysfunction, and loss of bone mineral density during the pre-participation evaluation. Athletes identified as having one or more components or who are found to be at risk should be referred to a specialist experienced in the evaluation and management of this condition. A multidisciplinary team approach to evaluation and treatment of disordered eating is the preferred method of care. The treatment team should consist of a physician, nutritionist, and mental health provider. Additional team members may include an athletic trainer and strength and conditioning coach. Coaches are discouraged from active participation in the treatment of eating disorders. In addition to conflicts of interest, coaches may be perceived to pressure athletes for example, in maintaining a place on the team or continued scholarship support. Continued participation in training and competition depends on the physical and mental health of the athlete. Athletes who weigh less than 80% of their ideal body weight may not be able to safely participate. Athletes with evidence of health consequences of disordered eating, such as electrolyte disturbances, anemia, hypotension, bradycardia, syncope, depression, suicidal ideation, or intent, should be closely monitored by a physician. Medical safety should be ensured before allowing an athlete to return to training or competition. In 2013, Chief Medical Officer Dr. Brian Hainline declared mental health as the #1 health and safety concern in the NCAA. There are more than 200 pages of mental health documents buried deep in the NCAA website, a quarter of which focuses on women's issues alone. Menstrual dysfunction in athletic women generally presents as secondary amenorrhea or oligomenorrhea. Pregnancy must be excluded as a cause of menstrual dysfunction. Assessment of menstrual dysfunction should include medical, menstrual, reproductive, and family history, and specific questions related to disordered eating. The physical examination should include a pelvic examination, evaluation of secondary sexual characteristics, and laboratory evaluation targeting the most likely causes of symptoms. Athletes with prolonged oligomenorrhea or amenorrhea lasting for at least 6 months should undergo bone density evaluation by a dual energy X-ray absorptiometry DEXA scan. DEXA screening should also be performed on female athletes who have normal menstrual cycles, but have experienced 2 or more stress fractures. Exercise-induced amenorrhea occurs in athletes with variable frequency, but the incidence varies from 5 to 25%, depending on the level of competition and type of sport. A risk that has received little publicity is also related to the skeletal system and the development of scoliosis in young athletes with delayed menarche, particularly ballet dancers, where the incidence is 24 to 40%. Lastly, we need to look at the rehabilitation protocols that we are utilizing with our athletes post-surgically. Historically, most of the research has been completed on males, and this is where we are generalizing that the same ACL reconstruction protocol being used on our male population is just as effective when utilized on our female population. Knowing what we know about body build and hormonal differences, should we be using this cookie cutter method, or do we need gender-specific protocols? Lastly, I just wanted to show you guys a little bit of research that was found as I was going through and looking, just to kind of drive home some of the things that we are seeing with the differences in females and males. So one of the things obviously is our menstrual cycle, and as you can see here, some of the research is showing that there are irregularities that are being seen in our athletic population. So in the top you can see our general population, and it shows percentage irregularities in 2 different research go to about 5% of the general population, and those people are showing that there are differences in the prevalences of their the irregularities in their menstrual cycle, whether it be oligomenorrhea and amenorrhea, so either one of the 2. But whenever you go and you start looking at our weight-bearing sports and our not weight-bearing sports, you see a huge jump in the changes here with our percentages. So with the weight-bearing sport, you can see with ballet and with running, our irregularities jumped significantly. You can see in the first research there by Abraham that it jumps up to 79%. Now, they had a low number of subjects, but that is a huge number of irregularities within that population. And you also have to look at, obviously, these are female sports, clearly, and they are, wearing little clothing, so then you have the body discrepancies that they are having, which could be leading to eating disorders, which therefore could be leading to our menstrual irregularities. So that is something that we need to keep in mind, which kind of just proves our point that we need to be looking into these differences in our female population. So therefore we need to be having better pre-participation physical exams to help better find these differences, these irregularities, so that we can help our student athletes better perform and have a better life in general.
From a coaching perspective, there are also a number of ramifications that stem from the gender differences between men and women. Personally, on my small tennis teams, I have experienced a greater amount of injuries on the women's side. A number of factors could contribute to this, including structural differences such as Q angles, general hypermobility without the appropriate motor control, overall durability, and in some cases decreased core stability. As a consequence, I generally have to create and oversee two separate plans, conditioning and practice plans each day for both teams. And this is definitely a challenge since both teams practice at the same time and I'm the only coach for both programs. So essentially, this means that I am the only eyes and ears out there to help ensure the safety and well being of all of the student athletes. A final issue that I deal with as a coach is with in season nutrition. On the men's side of the coin, my biggest challenge is getting them to make good food choices. However, on the women's side, they tend to be a bit more calorie shy, even in season when they need the calories the most. Given these ramifications, it would be ideal to address new strategies or policies to help athletic trainers and coaches better deal with the uh, issues of gender difference. So, to set the stage for that, let's take a look at Porter's 5 competitive forces that shape strategy and impact policy development. According to Porter, all industry structure and strategic planning revolve around 5 forces, which include rival competition, savvy customers, powerful suppliers, the threat of new entrants, and the threat of substitutes. So let's just briefly discuss what each of these means. Rival competitors simply refers to the business across town or across the street that offers similar products and services as you do. This force generally limits profitability through price discounting, creation of new services or products, and aggressive marketing. Savvy customers refers to the bargaining power of the buyer. When products or services are standard, when the cost to switch between suppliers is low, and when there is high potential for buyers to enter the industry by making or providing the products and services themselves, buyers typically have a lot of bargaining power and can therefore force prices down. Powerful suppliers, on the other hand, is the polar opposite of savvy customers, refers to the bargaining power of the provider. A supplier can become powerful when it is more concentrated than the industry it sells to, when the supplier's revenues do not directly depend on the industry, when the cost to switch suppliers is high, when suppliers offer unique or specialized products and services, and when little to no other substitutes exist. Threat of entry refers to the ease at which new businesses can enter a particular market. If the threat is high, meaning it would be quite easy for a new business to enter, existing businesses must keep their prices low to stay competitive or deter the new entrants. The threat of substitutes refers simply to any new products or services that perform similar functions to those you offer. Threats are high when the buyer's cost to switch to substitutes is low and when the price performance trade off is fairly attractive. These 5 forces are typically related to business and profitability. However, they can directly impact policy making even in the athletic training and coaching worlds. So let's look at a few examples of this. In athletic training, if a provider of necessary athletic training equipment should all of a sudden become too powerful for whatever reason due to their geographic location or whatever the factors might be, they can drive the costs of their equipment up. And this would essentially leave the athletic training staff and the administration with some hard choices to make. If they buy that equipment, it might mean them foregoing purchasing other equipment that they might need. Or it might lead to limited services that they can provide. In some cases, they might not be able to provide the services at all and might have to outsource to others. ultimately, it will lead to a change in policy and protocol for how the athletic trainers treat their staff. Another good example of this might be in the case of gender differences. Say a institution wants to ask that their student athletes receive specialized screens, but say there's only one doctor in that area that provides that. That doctor then becomes a powerful supplier. And again, the administration, the athletic training administration, is essentially at the mercy of that supplier to essentially dictate the costs. And then essentially the administration, the athletic training staff, they have to actually budget around that. So again, they're limited, and policies then need to be created based on that. From the coaching side, again, the same scenario can happen with a powerful supplier, raising costs, which then limits the benefits and services and sometimes the size of the roster of teams. And ultimately, this will just lead to poor recruiting and also poor future for the program. One other example from a coach's lens is when we look at the savvy customer force, and in this case, it's the savvy student athlete who shops around for the best and most competitive financial aid package, which is a natural process in the college search uh, process, but it naturally will drive down profits as institutions compete, sometimes stretching their limits of and their means. Profits will dip down. Again, that will lead to policy changes at the admissions level, as well as policy changes for coaches and how they are required by their institution to recruit. So hopefully this gives you a sense of how these forces can play a role in shaping policy. I'm going to hand it off now to Whitney to actually discuss some of the policy changes that we suggest regarding the issue of gender differences.
As Stephanie and Jeff have discussed, there are several potential ramifications from insufficient female specific health care in athletics from both an athletic training and a coach's perspective. These ramifications can be the drive for development and implementation of policies in order to address and proactively resolve these issues. First, we're going to discuss athletic training policy development. From an athletic training perspective, policies should be created to develop aspects of the pre-participation exam to be female specific, including but not limited to bone density scans, gynecological examinations, and CBC panels. Bone density scans can collect information to alert healthcare professionals of female student athletes with inadequate calcium retention that can lead to the prevalence of stress injuries or complete fractures. Assessing hormonal levels and overall vitamin and nutritional information with blood work can alert healthcare professionals to athletes who may be predisposed to or already suffering from things such as anemia, inadequate iron retention, or inadequate hormones necessary for mental stability. Implementing a policy that mandates these screenings for female student athletes can increase the health care they receive and aid in the prevention of and treatment of potential injuries. However, this requires administration to procure the appropriate healthcare professionals such as phlebotomists, OBGYNs, and medical technicians to administer the required testing. As a staff athletic trainer who isn't in the development process of the policies, but rather the implementation and application of these policies, workloads are increased by the demand of screenings and tests to be carried out. As the information that is collected during a pre-participation exam increases, so does the amount of time spent completing the exams for all student athletes. The amount of time analyzing this data also increases, which increases the workload of each staff athletic trainer if manpower is not increased concurrently. There is the potential for staff to be disgruntled as their workload demands increase without an increase in benefits or salary. From a coaching viewpoint, a policy on female nutritional documentation is crucial to monitoring caloric intake of student athletes. From previous conversations with Jeff, he discussed that he has personal experience with his female tennis players being extremely mindful of the calories they consume on a daily basis, almost in an extremely restrictive manner. Developing a policy mandating the use of nutritional documentation through an app such as MyFitnessPal can assist coaches in monitoring what their female athletes are consuming. This app allows goals to be set, such as overall caloric daily intake, maximum number of macronutrients to consume, such as fats or carbohydrates, and it also provides feedback for the user, such as this food is high in vitamin C, or this meal contains 32 grams of sugar. Remember, your daily goal is to consume no more than 40 grams. This app can be educational for the user, but also allows coaches to be mindful of both quantity and quality of the foods their athletes are consuming. Also, implementing a policy that states conditioning programs should be gender specific is also helpful in the prevention of and potential decrease in severity and rates of injuries. As we know, females do not respond in the same way to a standard treatment as their male counterparts do. These differences amplify that strength and conditioning workouts for opposing genders should be tailored to their specific needs. If the females on a tennis team are hypermobile, why is flexibility a concentration solely because their male counterparts are completing these exercises due to their hypomobility? Developing these protocols for each gender increases the workload of the leader or the coach up front. However, as we discussed with Jeff, it may decrease the overall workload during the season as there may be a decrease in the rate and severity of the injuries. This would decrease the occurrence of coaches creating those Band-Aid type rosters in order to fill the gaps of players on the DL with injuries. Increasing the amount of responsibility of a coaching staff can increase workloads of an already overworked staff. Specifically, at small institutions where coaching staffs are typically low in number and often asked to coach multiple teams concurrently, these policies would drastically increase the already heavy workloads. This would be an instance where working more efficiently is necessary. As we've discussed in this screencast, policies created for female-specific aspects in athletics is necessary. However, we understand that male-specific policies should be created as well. We feel that all student athletes should be considered equally. However, that does not have to mean that they are assessed nor treated with the exact same screenings or exercises. Tailoring healthcare to be gender specific can only increase the quality of healthcare that our patients are receiving and increase the care we as healthcare professionals provide.